So today I'm going to be talking about translating focal laser ablation to an office-based procedure. And this is this technique we performed about 4 years ago under the subject of an investigator-initiated grant sponsored by Medtronic. And then subsequent to that, the subsequent work was under an academic industrial partnership grant with UCLA. So the motivation for exploring fusion-guided FLA, or the concept is, if you can biopsy a site, go back to the same spot and characterize it over time, why not go back using the same technology and ablate it where it lies? So motivation is ease of use, the same approach as a biopsy, transrectal or transperineal, shorter time and less resources required, because for a urologist, when we performed our first 8-patient clinical trial, it took an average of about 4 hours to perform that procedure. Now, we've only done 8 patients. Others that have presented at this meeting have a lot of compelling data about MR-guided in-bore laser, but we found that it was quite difficult to use and cumbersome. The final reason was that we had a real problem with MRI thermometry. MRI thermometry works great if the patient's not moving, if you can have a really accurate idea of what the baseline temperature is, but as soon as the patient starts moving and as the procedure goes in time, the thermometry image gets distorted, artifacts appear, and the damage calculation, this is provided by the Visualize software, really is inaccurate. And this is a comparison of a thermal probe reading, direct thermal probe reading versus MRI thermometry. And you can see the increased noise in the signal. So we performed in 2016 an exploratory pilot study. And this was a feasibility study with the purpose of addressing safety of translating focal laser ablation to an outpatient office-based procedure. So we attempted to treat 10 patients with grade group 2 and 1 patient with high volume grade group 1. We used interstitial thermal probes instead of MRI thermometry. We placed 4 probes, 3 of them transperineally and 1 of them transrectally using a custom needle guide. And this is with a commercial fusion platform so that we can monitor what's happening at the laser tip always, as well as some critical areas around the expected treatment zone. So I'm just going to go briefly through the results because this has been presented several years ago. We found that we were able to successfully treat 10 of 11 patients. 1 patient had a large TURP, and we weren't able to effectively treat this patient. We found that the mean non-perfused volume was 4.3 cc's. We found that all patients safely tolerated the procedure. There were no hospitalizations. There was no decline in sexual or urinary function, and it had a pretty good safety profile measured by IPSS and Shyam. Also, patients tolerated the procedure from a pain perspective. For cancer control, we had some problems early on. We found that lack of visualization of the laser fiber under ultrasound guidance really caused a lot of the problems because we weren't hitting the right area. However, we now have 4-year data for some of the patients that have been followed, and we found that some of the early successes were durable across 4 years. So the main issue that we found with our failures was margins. So we went back, and I presented on our artificial intelligence margin-based prediction yesterday. We used the same algorithm to retrospectively look at if we used these kind of techniques, could we find the original cancer? Some of the patients went on to radical prostatectomy, so we had whole mount data afterwards. In the 7 evaluable patients, margins were correctly predicted the tumor burden in 6 out of 7, and the last patient was actually found to be ineligible because the margin was more than half the prostate. So this gave us some confidence. The second issue was in monitoring and visualization. MRI thermometry, while it has its limitations, is great because it provides a 3D map of what's happening in the prostate while the laser is firing. We used interstitial thermal probes. However, it was quite cumbersome, and we were measuring it at multiple positions without really understanding what's happening all over the prostate. The concept is if we could translate it to a single multimodal sensor and monitor what was going on everywhere in the prostate just by the data in that sensor, perhaps we can make this an easier and more feasible procedure. So this is work actually developed recent work that we used a multimodal thermal sensor to develop a computational model of what's happening in the prostate from a temperature perspective. And you can see the temperatures up here. You can see also the Arrhenius damage estimate, simulated thermal probe readings. This is comparing directly against MRI thermometry. And you can see our prediction closely matches the actual coagulation zone. We found that the MRI thermometry accuracy in an unmoving phantom was about 1.8 degrees. Our model accuracy approached that limit about 2.8 degrees. However, we were basing this on simulated thermal probe readings, whereas our actual interstitial thermal probes have an accuracy of about 0.25 degrees C. We also looked at real-time coagulation feedback. So we used the temperature information to actually map out what the coagulation front was doing. So this is a time series showing the coagulation evolution in a patient, or sorry, in a phantom. And you can see at multiple power levels, there was an average error of predicting the actual coagulation zone at all time points of about 0.39 millimeters. Keep in mind this is in phantom beta. We also developed a new method of monitoring the coagulation front directly using optical monitoring. Whereas with temperature, you have to get an indirect measure of what the damage actually is in a patient. With optical monitoring, we've developed a technique that can monitor the coagulation front in real time. So this is showing a time evolution of the coagulation front, and based on the optical signal, we can see a high concordance with the coagulation radius. So we brought both of those two things together in a single system. We developed this and manufactured this now. It's a multimodal thermal optical probe with a water-cooled laser catheter connected to our system, which is just a pump, a PC with a GPU performing all the calculations, and off-the-shelf diode laser. So this is what a urologist would typically see. This is an alpha version of our software. After a physician selects the ablation zone, collects temperature data, and then, oh, sorry. Yeah.
We come to your conclusions, please.
Yeah. This is the last slide.
Okay.
Yeah. So you would see actually the evolution of the temperature progress in real time. So it offers sort of a real-time visualization. And we also correlated with ex vivo tissue and found 0.5 millimeter error across all power levels. So in conclusion, we found that fusion-guided FLA is feasible, real-time coagulation monitoring is accurate, and we actually just received IDE and IRB approval to perform another clinical trial in the next couple of weeks, which we hope to enroll soon. Thank you.